All right, we'll go ahead and get started. My name is Kim, and I work with Dr. Lasasso and the pectus team. I'm often the first person that you speak to if you reach out to his office, so been fortunate enough to speak to a lot of you that are joining us today. Thank you, of course, for joining this webinar. We've been working to do a webinar a month with a different subtopic. If you have not had a chance yet, please go to nestprocedure.com to sign up for the webinar list so that you're aware of all of the upcoming webinars. But the webinars, as always, will be saved to the nestprocedure.com website. This is the third webinar in our series, and it will focus on bar removal. We will have a special guest today that will join us at the end of Dr. Lasasso's presentation. And then, of course, we'll conclude with the question and answer portion. So we encourage you to think about your questions, write them down throughout the presentation, and then at the that opportunity to review all of your questions. So thanks again, guys. And with that, I will pass it on to Dr. Lasasso.
Thanks, Kim. Thank you so very much. It's great to have all of you with me this evening. I'm coming to you from my home in Edgewater, New Jersey. And as Kim was saying, it's been very gratifying for us to be doing this webinar series. There's been a lot of interest that we have detected with all of you in the community regarding the information that we're attempting to provide you with. This is meant to be an educational experience for all of you, and we couldn't be happier that you have shown interest in the material. This is our third webinar, as Kim had mentioned, and this one is going to really focus on the end of the journey. Some of you may be at that point in your own personal journey. Some of you may be the family of someone who is at that point. There may be people that are viewing this that are just now coming to an awareness of their pectus condition, and we welcome all of you. We hope that this will be helpful to you, no matter where along the continuum of care you find yourself at this point. And I just want to encourage you all that if you have any specific questions related to your specific condition, if you could please call me or email me directly, and we could talk about specifics in that format, maintaining your privacy in doing so. For those of you who have been with me in the past, forgive me for going back through some basic background information about myself and a little bit about pectus in general, so that everyone has a fund of knowledge that will allow them to appreciate the information specifically that I'm sharing with you this evening. I did my undergraduate education at Yale University, and I went to medical school and did my medical school training at the University of Florida in Gainesville, Florida. I then did general surgery training at UCLA and at Cedars-Sinai in Los Angeles. And then I returned to the East Coast, where I did my pediatric surgical fellowship at Babies Hospital, Columbia Presbyterian Medical Center in New York. Thereafter, I returned to the West Coast. I joined the attending staff at the then San Diego Children's Hospital, now Rady Children's Hospital in San Diego, California, where I was the director of the chest wall deformities program from 1999 until 2016. I was directly mentored by Dr. Donald Nuss at the Children's Hospital of the King's Daughters in Norfolk, Virginia. And over the course of a year, spending multiple trips and time with Donald, I learned not only how to do the operation, but how to diagnose, treat and rehabilitate patients who undergo the NUS procedure. And for that, I will be eternally grateful. I am board certified both in adult general surgery and in pediatric surgery. Next slide. As I said, I was 20 years doing the NUS procedure to date. I've done 1,000 NUS procedures, both on adults and young adults. The youngest patient I've done is age 12, and the oldest 52. About 20% of the patients that I see and operate on are adults, as defined by 21 and older. In 2017, I moved my practice to the East Coast. I joined an old mentor of mine, Ranjidhir Gandhi. Dr. Gandhi was an attending surgeon at Baby's Hospital. During my training, our close relationship then led to a 30-plus year friendship, and given my interest in pectus surgery and the program that I had in San Diego, he enticed me to come back to where it all began, here in the Northeast, and joined he and his partner, my partner now, David Friedman, in practice in 2017. I do all of my pectus surgery out of the Valley Hospital in Ridgewood, New Jersey. And there I have both an adult and a pediatric program. Next slide. That was the Valley Hospital briefly that you could see, the entrance to the hospital, which is located in Ridgewood, New Jersey, about 30 minutes from the Newark Airport in northern New Jersey, very close to Manhattan, New York City. Next slide, please. This is my team that I'm blessed with. Allison Tan is the physician assistant that works with me and hand in hand to see patients and help them through their medical journey. Kim, who you just met, is the patient support person who answers a lot of your emails and questions and does a wonderful job maintaining my website in terms of responsiveness to all of you seeking information. Georgia and Linda are in my office. Georgia does a lot of the scheduling and handles logistical questions, and Linda is an excellent insurance expert when it comes to navigating the insurance waters and getting the approval process in order. So they're both real assets to this program, and I want to publicly thank them for their efforts. Next slide. Tonight's outline, what information I'd like to cover, includes just an overview of pectus in general, a little bit about what influences the timing of the removal of NUS bars at the end of the journey, a little bit about bar removal and what makes for a successful bar removal. I'd like to go over the steps of the procedure because I think there's a lot of questions regarding the actual way that one has their bars removed. Talk a little bit about post-op recovery. And then I've really got a special guest this evening, Brandon, who was a patient of mine who, together with Terry DeBro, on a program on the E-Network called Botched by Nature, Brandon and I were united, and I helped Brandon with a very unique pectus excavatum problem that just recently culminated in the successful removal of his NUS bars about a month ago. So Brandon is here with us tonight. Those of you who have seen the botched episode know of Brandon. I'll tell his story a little bit when we get there. And you can ask some questions of Brandon should you wish. but it was a wonderful journey. It was great working with Dr. Rowe, and it was great to get Brandon to the end with a very successful and very difficult reconstruction of his chest. And then the final will be a Q&A that we will take questions that have been texted to us and then questions directly from the audience. So starting with the overview, I want you to understand a couple of things about pectus. The first of which is that it's a genetic condition. It can present very, very early in life. About 20% or so will actually show up in the newborn nursery. The underlying cause is this genetic predisposition and growth. And what grows abnormally are the cartilages in the front of the chest. So your ribs are cartilage adjacent to your breastbone over to just about the side of your chest where the ribs become bone all the way back to your spine. And it's the abnormal growth of these costal cartilages that then leads to a buckling of the anterior chest, including the breastbone, in an inward fashion towards the spine, causing a concave or sunken chest. It is the most common chest wall deformity of all, and it's really quite common. It occurs in 1 in every 350 to 450 people. On a sunny day on any beach in America, you can walk down the beach, and I guarantee if you know what you're looking for, you can see someone with some form of pectus deformity. It affects men more than women, 4 men to every woman, and there are 3 types, the most common of which is excavatum or sunkenness. Carinatum is the next most common, where the chest protrudes, and the rarest form, seen in less than 1% of patients, is a combination, sometimes called a mixed deformity, where the upper part of the chest protrudes and the lower part of the chest is sunken. Next slide. Now I want you to understand how the bar works. This is incredibly important because it explains a little bit of what the miracle of the Nuss procedure is. And in addition, it begins to allow you to understand what's involved in the removal of the bar. So the first biologic event that's important for you to understand is when the bar is inserted into the chest, pushing the anterior chest forward, that creates force. And it's really force over time that causes those abnormal cartilages in the front, those abnormal cartilaginous ribs, which are bowed in, to be pushed out and into a corrected position. Literally, that force by the bar on the chest causes the cartilage to physically reconfigure itself. And that biologic process is called remodeling. So you can see in the diagram on the screen, the bar goes in this fashion, in this way, and it is flipped into this configuration. And when it does that, there's force towards the ceiling on the part of the bar that's inside between my fingers and inside the chest, moving the chest forward. And it's that pressure over time that causes the chest to become permanently reshaped. In addition, anything that's inserted into the body, be it a Nuss bar, a pacemaker, a artificial joint, is a foreign body as far as the body is concerned. And the body responds to that by a process called encapsulation. Think of it almost as if the bar over time has an envelope of scar tissue that encircles it and in the case of a nuss bar, serves to hold the bar in place. So it serves a very important function long-term in that it really is the source of anchoring the bar in the body. Next slide. So what are the factors that affect how long the bar should, or bars, should be in the chest? So there are a couple of issues that help to answer that important question. The first of which is, when is it optimal to put the bar or bars into the chest? The standard answer for that is somewhere between the ages of 13 and 15. But really, the answer to that question is dictated by how severe the patient is sunken, what the emotional maturity of the patient is, and what their gender is. So how do those factors influence? Well, if one is extremely severely deformed, you may want to opt to do it a little bit earlier than if someone is only mildly or moderately deformed. The other issue is the person who is undergoing the procedure needs to have the emotional maturity to participate in that decision and has to be able to participate in the recovery from the procedure, which entails physical therapy and other aspects of recovery that we've covered in webinars past. So I would encourage anyone who's interested in a deeper understanding of that process, refer to the earlier webinar where I deal with that issue in depth. And then gender becomes a factor because in women whose chests will undergo feminization, it's important for that process of breast development to occur on a corrected frame, on a corrected foundation. It will then promote the more normal development of the female chest. And so that becomes a consideration for patients who are female. One may opt to do it a little sooner than later, depending upon how soon breast development is occurring. Where severity comes into play is the symptomatic patient with a very, very severe and high Haller index may be an individual that you would want to do sooner than later. The earlier in life the bars go in, the longer they have to stay, because remember, as one grows with this condition, one will sink. One will have further progression of the process of the chest wall sinking. And it's important to know that so that you can intervene at an early time and keep the bar in until growth has ceased. Next slide. So for all patients, the bottom line is you want 3 years at the very least for the bars to work their magic and reconfigure the chest. It's the same timeline for both children and adults. In some cases, as we just mentioned, when one would, due to severity, gender, or symptomatology, want to intervene earlier in life, then you may have to keep the bar longer than 3 years, simply because you don't want to remove the bar if the patient is still growing. So growth is monitored carefully, and as a general rule of thumb, if someone is growing at a rate greater than an inch a year, or put another way, a half an inch in 6 months, then in my opinion, it's important to not remove the bar in such an individual until their growth is less than that, to prevent prematurely removing the bar, growth occurring thereafter that causes a slight recurrence. Next slide. So a little bit about the procedure itself. It's very different than bar insertion, okay? It is an outpatient procedure. That's the first major difference, which means you go home on the same day of the surgery. It does require general anesthesia, however, okay? Another important difference is that in bar insertion, there is a substantial amount of work that needs to be done inside the chest. The separation of the deformity from the underlying heart and placing the bars into that space requires a lot of work inside the chest cavity. That's not necessary with bar removal. Essentially, the bar is removed from the end of the bar here, which can be accessed through the incisions on the side of the chest. Once the end of the bar is exposed, then the bar can be straightened. And so that part of the operation is subcutaneous, meaning just under the skin. It is a shorter operation. It entails maybe 1 to 3 hours, and there's much less postoperative pain and discomfort, and therefore much less need for narcotics to deal with the pain of bar removal. And finally, the recovery is much shorter, whereas bar insertion requires weeks and months to recover, entailing the acute recovery and healing, plus weeks to months of physical therapy. With bar removal, that's not necessary. Next slide. A very important point I want to make at this point in time is the answer to the question of who should remove your bar or bars. And unequivocally, for reasons I'm going to stipulate, the surgeon that inserted your bar or bars should be the same surgeon that removes your bars. The most important reason for saying that is that it reduces risk. Surgeons have slightly different techniques in how they do a NUS procedure. Think of the NUS procedure as a general outline that the specific surgeon adds his or her specific touches to and creates an operation that is his or hers uniquely. Those variations of the NUS procedure can greatly influence what the challenge might be in removing the bar. So the surgeon who put it in should be the surgeon who removes it. The original surgeon will always have a better understanding of you and your journey, and it's important that there is continuity of care. And the original surgeon, the surgeon that put the bar or bars in, should be there for you at the end of the journey to finish the job and successfully complete the procedure, which entails removing the bars. Next slide. So the person pictured with me on your right is Brandon, who we'll be hearing about shortly. And this is where I want to explain to you what the steps of the procedure are. So, first and foremost, you'll be completely asleep. It's done in an operating room, and it's done with complete and total general anesthesia. So you should not and will not feel a thing. The original lateral incisions are used to access the ends of the bar on both ends, okay? The capsules, remember we talked about encapsulation, that needs to be open. So where the bar is at the end, just under the skin, that is accessed through the incision on the side. The capsule or scar tissue around the bar needs to be opened. And sometimes this is the first point in the operation where things can be challenging. The bar or bars can be completely encapsulated in bone, like the adjacent rib, and it can be sometimes actually difficult to know what's bar and what's rib. At times we even need to use special instrumentation and intraoperative X-ray to be able to localize the ends of the bar. But once that's done, then if it is bone over the bar, that needs to be removed. And then any of the additional hardware that might be on the end of the bar needs to be removed. In some instances, this plate called a stabilizer can be on the end of the bar like this and needs to be removed such that the end of the bar under the skin can be straightened, okay? The straightening of the bar is extremely important. It has to be done as near perfectly as possible. And in addition, the part of the bar that is outside the chest but under the skin needs to be freed completely so that the only part of the bar that is still within the capsule is that portion which is in the chest and above the heart. That part is protected by the capsule and can be easily removed through the capsule through just gentle traction. It's important that it come out easily. There cannot be any excessive force used in removing the bar. Once the bar is removed, that capsule needs to be closed meticulously along with the other layers of the chest wall. And before the patient leaves the operating room, an X-ray needs to be done to confirm that all of the implants have been removed. So every bar and every stabilizer and any wire that might be used to connect the stabilizer to the bar has to be documented that it's removed and that there's been no accumulation of fluid or air in the chest as a result of having the bar removed. So everyone gets a chest X-ray before they leave the operating room. Next slide. So pain management is as important in bar removal as it is in bar insertion. The good news is that the amount of discomfort that one should expect to feel with bar removal is much, much less than what occurs during bar insertion. Think about it. When the bar is inserted, the chest is deformed. The chest is sunken. It has to be lifted. A tremendous amount of force has to be applied to the chest to accomplish that. The chest goes from sunken to corrected in the time it takes to flip a bar or bars. So it's a very abrupt change in the anatomy of the chest wall, creating trauma and stretch on the chest. That's what the source of the pain is with insertion. With removal, if done properly and meticulously, it should be a much less traumatic event. You open the skin, you open the capsules, you bend the bar straight, and you gently pull it out. The amount of trauma is very much less than with insertion. Therefore, the amount of pain management is much less. And therefore, we can use just Tylenol and Motrin. Narcotics are only used for rescue. What we mean by that is if Tylenol and Motrin postoperatively is not quite enough, then narcotics can be used to get the patient to a point where they're comfortable. But what really, in addition to meticulousness, reduces the pain, in my opinion, is the use of this new long-acting local anesthesia called Exparel. It's a very special local anesthetic that is chemically different than standard local anesthetic in that it is time released. And therefore, because it's bound to a liposome, which is the figure that is to the right of your screen, that prolongs the effect of the local anesthetic up to 3 or 4 days and goes a long way to reducing the pain that one perceives from the operation. I like to use it along where the capsule's been closed and liberally in the tissue around the incision. I have found in my practice, using Exparel, I can have patients wake up with a sense of not even feeling as if they've had an operation and able to go home on non-narcotic medications with great pain control. So I would encourage you out there who have bars and are going to have them removed to talk to your surgical provider and ask if they're familiar with Exparel and encourage them to use it as a local anesthetic of choice to minimize the need for narcotics and to maximize pain control for you all. Next slide. So postoperatively, what should you expect? Well, if you're one of my patients and you're coming to me, you should expect about a 10-day stay if you're having your bars inserted. But if you're having your bar removed, that can be generally accomplished, including travel time, within a 4-day span of time. So a lot less time involved. Generally, I have people come the day before, the next day they have their bar removed, the next day they stay in New Jersey with me, and if all is well on the following day in the late afternoon, they can leave. So that is a very efficient way of getting patients to have the procedure, have it done safely, have enough time to ensure that all is well, and then patients can get on planes and leave. And that has been a winning formula for me in my practice. You're able to shower immediately afterwards. I use a dressing of a liquid tissue glue over the incisions, which allows the patient to shower immediately, and there's no dressings to change, and that material just sort of flakes off like old nail polish off a nail bed. So it's just easily managed. It doesn't require any dressing changes, and I have found it's a very good protective dressing. When can you go back to doing the things you love to do is always a question that patients ask me, and I've got a very simple formula for that. I say when your wounds are healed, which is usually about a week to 10 days, the swelling, which is normal, has completely resolved, and that swelling is from, the the trauma to the skin to lift it up and expose the bar, the trauma to the tissue that has to be opened and closed around the bar, and then the use of the local anesthetic into the tissue causes swelling. When all that swelling is gone, the wounds are healed, and finally, there's no pain with your typical daily activities, brushing your teeth, combing your hair, reaching for a bowl on a shelf. When those things become pain-free, then you're able to go back to doing all the things you love to do. In general, in my experience, that's somewhere between 2 and 3 weeks after the bar's been removed. Next slide. So here we come to the end of the didactic lecture. I want to now introduce Brandon, who was the patient that Terry Dubrow and I helped on the Botched by Nature program. And in this little segment that I'd like to show you, it's about a minute and a half. Brandon tells his story, and his story is going to resonate with all of you out there listening. It's a very common story, a story of there not being a lot of information, of wondering what it was that he had, and trying to struggle to find someone who could safely and completely repair the condition. So with that, it's about a minute and a half. I'll allow this video to run, and then I'll tell you a little bit about what Dr. Dubrow and I did to correct Brandon's unique pectus condition, and then we'll talk to Brandon.
It's a pretty surreal feeling having them here. These are some pretty well-known doctors. Here they are, not only in Iowa, but they're here in my house.
How old were you when you first heard the diagnosis, pectus excavata?
I was actually about 19.
19. So what did you think was going on before that? Or what did doctors tell you?
Nobody ever made any mention about my chest.
Pediatrician
being an issue now.
I'm surprised a pediatrician would miss pectus excavata, particularly when you consider he's applying a stethoscope to the chest all the time. At some point, though, when you were 10, 11, 12, your friends were taking their shirts off, did you start to feel self-conscious about that?
Absolutely. After noticing it when I was like 7, from that point on, I remember never taking my shirt off if we weren't swimming with my friends and my family. I always tried to cover it.
His older siblings and I might tease him a little bit about it. His abdomen seemed larger because of the cavity in his chest. So he just looked like he had a little pot belly.
When you're a kid growing up, everybody looks for a reason to make fun of you. I went swimming with a shirt on. Kind of had a little bit of a complex about that.
Any problems with exercise or anything? Shortness of breath?
Shortness of breath, yeah. I've always been pretty active.
Yeah.
I've noticed that it kind of affected me. There is a health issue there. My lung capacity is a lot smaller than most people because of the way the rib cage is pushed in.
The further it goes in, the more it compresses the lungs and the heart.
Okay. Well, I think the crux of the story was communicated. Brandon, instead of having a operation to structurally change his chest, he had an implant placed, and that implant then led to further complications, which then brought him to Dr. Dubrow and I. The implant needed to be removed, and it was removed successfully. And then 3 months later, a NUS procedure was performed by me in which 2 bars were successfully implanted into Brandon's chest, resulting in an excellent outcome. And then a month ago, Brandon came out here to New Jersey, and the bars were successfully removed. So the journey started in San Diego and it ended in New Jersey, and I couldn't be happier for Brandon and his family that the journey had a wonderful, happy, and successful outcome. I received in my email, in my inbox yesterday, a little greeting that I wanted to share with Brandon and with the audience. So if we hopefully this will project better than the last video, but let's show Brandon and the audience the next video.
Brandon, Rowe.
There we go.
Amazing. Hey, it's Dr. Terry Rowe from Botched. I want to give a huge shout out to Dr. Barry. Hey, it's Dr. Terry Rowe from Botched. I want to give a huge shout out to Dr. Barry Lasasso and Brandon Robb for their amazing work on Brandon's pectus excavatum, incredibly difficult revisional case, but Dr. Lasasso killed it as always. Congratulations, Brandon. You're a stud. It looks amazing. And thanks so much for allowing us to show your journey on Botched. Congratulations. Take care.
So that was a great surprise, and it was wonderful to work with Dr. Dubrow and the whole crew at Botched. And the best part of the journey was meeting Brandon and helping him to have such a wonderful outcome. So Brandon, I know there are people out there in the audience who would love to hear from you, to sort of hear directly from you what your journey was like, and specifically, how did bar removal compare to bar insertion?
Am I on? Or?
Yes, we can hear you. Thanks.
Okay, sorry. So first of all, I haven't seen that picture of my chest with that implant in, well, 4 years. That's, I can't believe it looked terrible. But I also want to say, you know, everybody that's watching this right now, how incredibly lucky you are. Everything that you've heard from Dr. Lasasso over the last 30 minutes, that information, you know, I didn't have any of that, you know, 20 years ago when I actually started this. I was 19 in 1999. The internet was barely around. I went to a plastic surgeon. I don't know how much, I don't remember how much of my story I was actually able to tell on the show Botched by Nature. But I was referred to a plastic surgeon back then, and he gave me 3 different options for correction of pectus excavatum at that time in 1999, and 2 of them were absolutely terrible. All right, and to be honest with you, I didn't know at the time. I was in the way wrong place. That guy had no business giving me any information at all. He should have referred me to somebody like Dr. Lasasso. And just because I don't know, I don't remember. I only watched the episode 1 time since it aired, but I don't remember the details on it. And I'm just trying to keep this short and sweet. But the first option that doctor gave me was to cut my rib cage on both sides. And I don't know if you guys can see me right now. But he wanted to cut my rib cage on both sides, take my rib cage out, flip it over, and put it back in. And, you know, I'm 19 years old and terrified of that. Like, are you kidding me? That's not happening. So I'm glad I was smart enough at 19 years old to say, no, it's a terrible idea. The second option, he wanted to bust my sternum up and just kind of pop it up another way. And the third option that he had was to take a mold of my chest and have a custom implant made. And I was like, you know, ding, ding, awesome. I'm healthy otherwise. I just want the cosmetic look to look better. And so back then, you know, it was just all about, I just wanted to look better. And that seemed like the safest route at the time. So I did that. And, you know, I wasn't overly happy with how it looked, but in my opinion, it looked better than a big hole in my chest. And, you know, I had a complex about it, you know, growing up, like a lot of you out there listening probably have experienced as well. So for, 15 or 16 years, well, about 15 years, the implant was, fine. I was living with it. It's about 5 or 6 years longer than an implant like that is supposed to be in your body. Started developing an infection, and that's what you see in that picture. That's why, it really didn't look as bad as that before the infection. But that picture that I'm looking at right now, there was a lot of fluid developed around the implant, and that's why it was popping out like that. So then, when I got in touch with Dr. Lasasso, I started learning a lot more about the Nuss procedure and how that all works. And even then, I still did not get all the information. I mean, I'm not saying he didn't give me information, but to watch this on this webinar, like you all are able to do right now, is amazing. I mean, this information is great. Just listening to him talk for the last 30 minutes and really walk through everything. I wish I would have had that, 20 years ago, but I didn't. So,
Listen, Brandon, I think we made the best of a bad situation. And I think it was the skill of Terry to get that implant out, and us together to, get your chest structurally where it needed to be, which is in this new corrected position. Can you talk a little bit about what life has been like now that you're, beyond the acute phase of recovery from your Nuss procedure? What things can you do now that you really felt were very difficult for you before the procedure?
Before having the bars put in?
Yes, correct.
I think that for me, I was lucky enough. I was fairly healthy with the pectus. For me, it was just the cosmetic. But I will say that I do notice that I can breathe better. And I didn't notice it as much when I had the bars in as when I had the bars removed. The very next day after having the bars removed, I noticed an instant difference, and you might be able to elaborate on that, why that is a little better than I can. But from what I understand, and I think probably because I weightlift, there's a lot more calcium buildup around the bars. So over the course of the 4 years that I had my bars in, more calcium is building up. So when you took the bars out, you took all that calcium out, right?
That's correct.
And I had an instant more space, I think. I feel like, maybe I'm wrong, but that's just what I felt like. I feel like I can really take deeper breaths and just breathe better. I notice it in the gym when I go to the gym. Like I feel like I just a lot better. So
that's wonderful. And in fact, your bars had so calcified, it was like you had 2 extra ribs in your chest. And it's not a surprise to me that gave you a sense of restriction, especially when you were working out and doing things that required deep breathing. So I'm so gratified to hear that, your breathing is more normal and that you're feeling better now with the bars out. It's unquestionably one of the best corrections I've done, considering just how severe you were and all the other issues that we had to deal with in order to get you to the finish line. So it's very gratifying to me to hear that you're doing so well, and I really appreciate the confidence you had in Terry and I to entrust your care in us, and I really appreciate you participating as you have in this webinar this evening. It means a lot to me. Thank you so much for.
Absolutely, and the recovery from having the bars removed was fast. I felt fine within a few days, and back in the gym a few weeks afterwards. I took it as slow as I could, but that's just my happy
Brandon,
place.
I know and love. Always pushing the limits. That's fantastic.
Yeah.
I'm good to hear that. Listen, did you need to use any of the narcotic that I gave you? Was the Exparel and the Valium and the Exparel and the Motrin and Tylenol, was that enough? How much of that did you need to use?
I only used Tylenol and ibuprofen, maybe something. I just went back and forth between just 2 over-the-counters. For me, when I had the bars put in, I was so scared that, after the bars were put in, I didn't want to get to that point where I was hurting. So I think that I was taking the hard medication on a regular basis. And I don't know if you remember, but like when I tried to wean myself off of that stuff, I had a bad experience because I probably took it a little longer than I should have, just because I didn't know, I didn't want to come off of it too soon.
Yeah, I do remember.
But I ended up having withdrawals, in my body. I didn't, I've never experienced anything like that before, but I had withdrawals. So you told me to go back on. And so the next time that I weaned myself off of that, I took a lot more time to make sure that because I put my body in pain because of that. So this time with the bar removal, I really didn't want to take anything hard. And to be honest with you, I didn't need to. I was not in any pain at all on the bar removal.
And that's in the face of having to remove a lot of calcified, tissue from around the bar. It was a very, very challenging bar removal. And that's where I think, doing it meticulously and also using Exparel makes a world of difference. So I'm so glad to hear that it was as smooth as it was, because in the operating room, it was a challenging bar removal, to say the least. So I'm so glad that you're doing well and you continue to do well once you returned home.